So hello everyone, my name is Vishnu Mohan. I'm faculty here at DMICE, and I'm here to introduce my intern for the summer. Before I kind of get into that, I do want to start by thanking everyone who is responsible for this internship program. It is a outstanding experience, not only for the interns who are here with us, but also for the faculty that are associated with them. We learn as much from you guys as you learn from us, especially in informatics because it's so collaborative. And so with that, let me introduce Song K, who is our intern for our research group for the summer. We are very fortunate to have her for the summer. She's going to talk a little bit about herself and also about the project that she was involved in, which has to do with electronic health records and how we can improve patient care and patient safety specifically. So without further ado, let me ask Song to get started here.
So hi everyone, and okay. Hi everyone, I'm Song, and today I'm here to talk about improving patient safety through information. So a little bit about myself. I'm a senior at Oregon State University, majoring in general science pre-pharmacy, with a minor in computer science. And my mentor is Dr. Vishnu Mohan. So for my presentation, I'm going to first give you a big picture of the project the research team and my mentor are working on, and then explain my role as an intern and my contributions to this project. So there was a report published by the Institute of Medicine back in 1998, which stated that every year 44,000 to 98,000 people die due to medical errors that could have been prevented. Out of all of these medical errors, we are only focusing on the electronic health record related errors. And there are many ways to reduce errors and focus on errors, and we are only going to focus on these three objectives, which is developing an EHR simulation in the ICU, providing training to the user, and improving the EHR interface. For those of you that don't know, Epic is an electronic health record application that's adopted by OHSU. It is also the number one most adopted software in the United States. And for our project, the setting is in the medical ICU, and the participants of our simulation are postgraduate medical trainees, which includes interns, residents, and fellows. Our simulation method starts with a fake patient case that we built into the system that contains 14 problems and traps in the case. We then provide the subjects with 10 minutes to review the case within Epic, and after the 10 minutes, the subjects are required to present the patient as if they're rounding. Last but not least, the subjects are given feedback on how they use the EHR by one of our doctors. So here's an example of the eye tracking software that we've been using to record the subject's eye movement across the screen. This is an example of a heat map produced by the eye tracker. The colors red, yellow, and green shows us the duration the participant is looking at the screen. For example, for the medication fentanyl over here, we can see that the subject not only looked at the name, but also moved across to see the specific date the medication was administered. So for our preliminary results, we picked 2 out of the 14 traps that were built into the case and tested the percentage of participants who recognized the errors during the first and second simulations. As shown in these 2 graphs, we can see that during their second simulation, they've improved. So I just gave a big picture of the project, and now I'm going to talk about my role in this project. To get familiar with the setting of our simulation, my mentor gave me the awesome opportunity to shadow in the medical ICU for 2 days with a fellow. During my shadowing, I realized 3 important things. Number 1, by nature, the ICU can be very chaotic. Number 2, all of the doctors and nurses are constantly working with Epic. And number 3, every patient, there are tons of data to be entered about every patient. So I'm not a clinician, and this shadowing has been a new experience for me. And to be honest, I was very overwhelmed, both by the critical care procedures and by the complexity of the environment after the shadowing. And most importantly, I realized that the ICU is a fertile environment for errors. Doctors are constantly faced with a large amount of data and a short period of time to deal with them. And this is when I realized why optimal use of the EHR is so important. After this overwhelming feeling, I found the motivation and the purpose of this project and was determined more than ever to contribute to patient safety. Going off of the complexity in the ICU, so how do we improve the EHR interface? Let me first tell you about a screen in Epic called the Epic Accordion Report. The Accordion Report is a highly configurable report that displays documentation data, flowsheet data, intake-output data, medication administration record data, lab results, and other patient information. The term accordion refers to the ease with which users can expand and condense the timeframes within the report. So based on the experience with the Epic EHR, the doctors on our research team realized a better way to organize all the items within the report based on organ system. For example, for the neuro report, we have vital signs, medications, and labs. And for the pulmonary report, we have vital signs, respiratory settings, medications, and labs. Here's an example of what I did. From the outline provided to me by the critical care fellow, the critical care doctor, each of these items has a specific ID in Epic that I had to, that are associated with the report. So my job was to go into Epic and find these IDs and to create the organization of how to create the new reports. For instance, over here we can see that temperature has the row ID of 6, and blood pressure on the second row over there has a row ID of 5. This basically acts as instructions for the Epic analysts at OHSU to create the new reports on the back end of Epic. Vital signs were only a small piece of the whole report. Perhaps the most challenging part of this project is working with medications. Again, using my outline from the pulmonary doctor and the help of a pharmacy informatician, I was able to generate this list of medications. And in order to do this, I first created a list of the therapeutic classes and pulled all the medications from each therapeutic class and organized into a list to be implemented as instructions to the Epic analysts, along with the vital signs. So now I'll explain another project that I worked on, which is building a patient case for the simulation. So in order to create a systematic way of testing our participants, we need to create a patient within the Epic system with 5 days of robust data. And these data points consist of the patient's hourly hemodynamics, medication orders, and labs. This is a snapshot of a file of what we call the cookbook in order to create the patient into the Epic EHR. We can see over here, and this is for the medication administration record tab of the Epic software. We can see over here, for example, Vanco, which is short for vancomycin, is an IV antibiotic. And my job was to enter 1 gram of vancomycin into at 9 o'clock and again at 2100. Along with the medication doses, I also documented the hemodynamics and notes from doctors into the system for the patient. Building a case took much longer than I expected, since this involved the work of multiple clinical roles. And oftentimes, those clinical roles included doctors and pharmacists who are on a busy schedule. So whenever we run into issues, we had to consult with the doctors. And this made me realize the real reality in the clinical informatics workflow. So although this project only contained 5 days of data of the patient, it took about 3 weeks to complete. So recalling back to the simulation, I talked about a software called the eye tracker. And this is a unique and valuable tool used in today's research world. My third project is going back to the eye tracking videos and analyzing the eye tracking videos. And by doing this, I use an Excel template created by our research team. And for each of the screens the subject visited, I created in the first column, I tracked the IDs that we used for the screen, and when the subject looked at that particular screen. And I also tracked down whether they looked at specific items across the top over there. For example, we can see over here, for the metformin dose view, in the first 4 minutes, the subject did not view the metformin dose. And this will then tell us about the patterns the user is using when using the EHR. So what I learned, the biggest thing I learned will have to be the flow of informatics. Before coming here, I never realized how interdisciplinary informatics is. It's really a place where data people and systems all come together. Computers are such a necessity now that more and more data points are being tracked into it. And informatics is important in that we need to make meaningful use of that data and to know how to interpret the data. Informatics helps form the knowledge. Along with informatics, I also gained many skills, such as using the Epic EHR software. In order to do this, I got the opportunity to go to an Epic training class with the OHSU residents. And I also gained skills using Excel and became a proficient user, as well as learning a valuable tool in today's research world called the Tobii Eye Tracker. Aside from those skills, I got many opportunities to attend meetings with healthcare practitioners who work with Epic and to troubleshoot, to gather together to troubleshoot those problems. This helped me gain an insight of the reality into the hospital workflow. Last but not least, I would like to thank the research team, my mentor, Dr. Vishnu Mohan, Adriel Gorsuch, who helped guide me through the project, the DMICE faculty, staff, and my fellow interns. Thank you. So, any questions? Julie.
For your first project out of the 3 that you mentioned, what did you do when there was more than one treatment class for a particular drug?
If there was more than one treatment class, we took the therapeutic class and picked the specific pharmaceutical class within that therapeutic class and pulled all of the medications out of there to generate the list.
I'm curious, what were the 14 traps that the clinicians had to catch?
That's a very good question. An example would be we purposely built something like over-sedation and tested the subjects to see if they realized they found that in the EHR case. Yes, please.
You know, that original IOM report came out before the widespread use of electronic health records. Is your sense that the ICU is now safer or less safe with Epic? Do you have any sense of that?
That's a very good question. Definitely with moving from paper to the EHR, we improved a lot of errors, and we were able to reduce a lot of errors. But due to the complexity of the EHR and more data points are stored into it, definitely there's also more room for error. So I would say there's pros and cons to it. Any more? Oh, yes, please.
I'll ask another one. So from what it looks like, you have data of what a clinician moves from when they look through the record. Mm-hmm. Is it automatically intuitive of why they jump from point to point when looking at different pieces of data in the record?
That's a good question. And I think because I don't have the clinical background, my mentor, would you like to chime in on that question?
I mean, I think the challenge is to try and figure out not just what errors are made, but why those errors are made. And one of the things that we're finding very interesting is that the pattern of use is very different for different users. We still don't know what the optimal pattern of use is, and that's something that we're thinking about as we progress with this grant and with our research. But there are 2 classes of users. There's one class of users who seem to know exactly where they're going and in what sequence they want to do things in. And there's another class of users who seems to spend more time just flittering from screen to screen to screen to find answers. The interesting thing is that we don't have, you would think that the purposeful user is a better user, but we don't have the numbers to prove that yet. I think it is contextual. The use of the EHR is very different than the linear use of a paper record. And I think the way that data is presented to people is really important in trying to figure out the best way to use it, as well as the training that each user has. So the best way that we think we can help to make patient care safer is to, what I call, build a better mouse and build a better mousetrap at the same time. And by that I mean improve the training that users have, and at the same time improve the interface that users are familiar with in order to improve both ends of the equation, so to speak.
Any other questions? Okay, thank you.
While we're switching presenters here, I'm Dave Dorr, and the next presenter is going to be Katie Cartwright from recently from Oregon State University. Actually, is graduating and going on to nursing school at Linfield. So she's been working with my team in Care Management Plus, specifically on a really interesting health reform issue about high-value elements needed to transform primary care in order to achieve the goals of health reform. So, it's been a pleasure to sort of look at this, and I think her study really is trying to get at, what is possible in this grand sort of set of initiatives we've been working on for the health reform under the Accountable Care Act and other initiatives here in Oregon. So great. And I want to echo Vishnu's thought. This was a great internship. We want to thank the National Library of Medicine, and who sponsors most of the interns here and certainly makes this program possible. So thanks.
Hello, I'm Katie Cartwright, and I'm going to be talking about the high-value elements of the patient-centered primary care home. So, like Dr. Dorr said, I'm a senior at Oregon State University, getting my bachelor's degree in public health with an option in health promotion and health behavior. I'm about to start Linfield Nursing School, and I'm originally from Seaside, Oregon. So here's a quick overview of what I'll be talking about. First, I'll be talking about the patient-centered primary care homes, which are a part of the health reform to improve primary care and patient outcomes. Then I'll be talking about TOP-MED, which is a trial to evaluate the patient-centered primary care home's effectiveness and how it can be improved. Then I'll talk about my focus, which are the high-value elements, which are part of the PCPCH that are said to make the most improvements. And then I'll talk about my project, which was a literature review on the high-value elements to see how much change is possible and how they affect the triple aim, which are the three main goals of the PCPCH. So the patient-centered primary care home is Oregon's version of the medical home model. So it's part of the healthcare reform to improve primary care. They focus on the whole picture of each patient and provide care on the basis of the patient's individual goals. They focus on, they are dedicated to improving the overall health of their patients by encouraging preventative services rather than simply just treating illness as it appears. They work as a team and coordinate care between the patient's primary care physician, specialists, nurses, and pharmacists. They have to meet certain requirements to be considered a patient-centered primary care home, and insurers pay the clinics based on how they meet these goals. They have 6 main components: access to care, accountability, comprehensive whole-person care, continuity, coordination and integration, and person and family-centered care. However, the medical home models are very complex, and some have over 100 elements within these 6 categories. The triple aim are the main 3 goals: population health and quality metrics, patient satisfaction, and cost and utilization, which is the main goal because our healthcare system is so expensive, and by reducing overall costs, we can help lower insurance premiums. There have been several studies on the effectiveness of the medical home model. Some have shown very large savings, like the non-randomized trials on large integrated systems. However, some have showed mixed effects, like the National Demonstration Project. Out of the trials that have shown improvements, the high-value elements have been derived and are supposed to demonstrate the most effective parts of the medical home model. Dr. Dorr and the team created TOP-MED to test these elements. TOP-MED stands for Transforming Outcomes for Patients through Medical Home Evaluation and Redesign. Its goal is to improve the quality of care for seniors and patients with chronic illnesses. It measures the safety, effectiveness, and experience of patients in the medical home models, such as the patient-centered primary care home. TOP-MED is a cluster randomized controlled trial. The control group focuses on all the components of the PCPCH, while the intervention group focuses on the high-value elements, which were created for the trial by an advisory committee based on expert opinion. The goals of TOP-MED are the same goals as the PCPCH. However, it was created to test if simplifying the patient-centered primary care home and focusing on the high-value elements could lead to more success. The high-value elements are those attributes of the patient-centered medical home practice that will provide the largest quality to the patients and cost benefits to the payers. They have 5 main components: identification of at-risk population, care management based on need, patient engagement and proactive goal setting, integrated information and procedures across settings, and population management tools. They're derived from the PCPCH standards, but are the ones thought to be most likely to improve the triple aim. However, if they actually do improve the triple aim is still unknown. So these are the high-value element standards. They each fit into one of the 6 PC-PCH components. However, they are refined to make them more simpler and measurable. For example, one for access is the clinic being open 12 hours outside of traditional business hours to reduce emergency department visits. For continuity, they follow up on patient care after hospitalization or an ED visit to reduce the amount of patients being rehospitalized. For accountability, they use performance data to identify where they can improve. For care coordination, they have outreach for high-risk patients to improve patient experience and outcomes. Under person and family-centered care, they provide written care plans to patients that are at high risk, also to improve patient experience and outcomes. And as a part of whole person care, they send reminders to preventative care services to improve population health. So for my project, I did a literature review on the high-value elements to find the strength of these standards. So far, the high-value elements have been based on expert opinion. So I wanted to see the best evidence of how much change is possible and to see if they could lead to success. I found 22 articles and did a data abstraction and wrote a summary. Now I'll give an example of a variety of articles that I found. The first is on after-hours access to care to reduce emergency department visits. It was a large cohort study that studied actual after-hours office visit availability and primary care practices and the rates of emergency department visits for their patients. It included 57,850 patients. The bottom row of this chart shows that with 12 hours, the relative rate is 0.8 compared to offices with no evening hours. This is a 20% decrease in emergency department visits at clinics that offered 12 or more hours outside of traditional business hours. This shows that improving access to care during non-business hours can decrease unnecessary utilization of services and reduce costs on the system. And the next is on patient-specific education resources and self-management services to improve patient satisfaction. It was a randomized controlled trial to explore the impact of health empowerment intervention on participation in goal attainment for homebound older adults. This diagram shows the intervention components. There were 59 participants in this study, and the majority of participants in the health empowerment intervention group thought that the sessions were very helpful to recognize their personal resources, recognize people to turn to for support, and progress toward the attainment of health goals. This shows that health empowerment interventions, including self-management skills, can increase patient satisfaction as well as their outcomes. The next study shows that sending appropriate preventative care reminders can improve population health through increasing screening rates, which will eventually improve patient outcomes by catching cancers earlier. It is on the effectiveness of using an email system to send reminders to patients and an effect to increase colorectal cancer screening rates. It was a randomized prospective cohort study and involved 2,100 patients. The table shows the percentage of patients that were screened in each group, and that with letter and email reminders, the percentage of patients greatly increased. These summary tables show the number of articles that affected each of the triple aims and the specific outcome that was affected. So the majority of articles focused on cost and utilization. 5 articles reduced emergency department visits, 3 articles found reduced hospitalizations, and 5 articles found reduced overall cost. For patient satisfaction, 3 articles improved patient satisfaction through education, and 1 through adherence to patient requests. And the last, which is population health and quality measures, 1 article found reduced mortality, 3 found increased screening rates, and 2 found improved quality measures. 4 articles altogether did not find a significant difference in the outcome studied, but none of the articles found a negative impact. Some limitations were that it was not a systematic review because not all the high-value elements had randomized controlled trials. Some of the articles used small sample sizes, and some articles had other factors contributing to the results. But in most cases, the high-value elements did make a significant difference in at least one of the triple aims. Although the level of evidence varies, these studies show that high-value elements have potential for success. The next step would be to continue Top Med and conduct more controlled randomized trials that could provide more evidence of the effectiveness of the high-value elements and continue to prove patient-centered primary care homes. I would like to thank Dr. Dorr and the rest of the team, and also DMICE and the summer interns. Questions? Yeah.
Thank you for your presentation. Could you tell us a little bit about your search strategy? What terms did you use? What databases did you use? How did you organize the literature that you found? And how did you exclude the ones that didn't end up making it into the 22?
Yeah. I used PubMed, and since there was 12 high-value elements, I found like 2 on most of them and only 1 on some, because some of them were very difficult to find a source that was like had enough. I looked at sample size a lot. A lot of the ones that were for patient satisfaction had smaller sample sizes because they were a small group to see. But for the bigger ones, like the one on after hours access, I wanted to make sure it was, like a trial with a lot of participants. So some of them were definitely a challenge, and it took a lot of searching to find ones that I thought were legitimate. Yeah.
Just as a follow-up to that, we got some data on 9 months of having urgent care, which is in our clinic open after 5 o'clock to 9 o'clock. 195 care organ participants, ED rate dropped by 50%. And cost as well.
Yeah. Yeah.
As the mentor, I'm going to exercise my right to ask a question. So it's interesting. You sort of describe what sounds like a pretty eclectic search strategy, sort of looking for each of the 12 high-value elements and seeing what's out there. Can you tell us a little bit about, were some of the high-value elements, did they have sort of more of a set of data already summarized and some less? You said the evidence varied. It seemed like you gave an example of one where really there was a model rather than, and one where there was a more of a proper study, at least a larger study. The question is, tell us a little bit about the variation that you saw amongst the 12.
Okay, yeah. So some were definitely easier to find, and because they've already, I think people know that's already important, and they're trying to show that. But some, like for care plans, there's a lot of different types of care plans, and a lot of came up were like care plans for kids with asthma and stuff like that. But for the high-value elements, it was more of like really high-risk patients. So that one was particularly difficult to find one that focused on all high risk. And then, yeah, I'd say patient satisfaction was one of the hardest too, just because it's, opinion. But a lot of them, if you go an extra step to help with patient satisfaction and come up with something to help, a lot of times, they are going to say that it was helpful. And so those were, they were good studies, but it's, it was difficult to find the actual scientific basis behind it. Anything else? Thanks.
While Connor's getting his slides up, so Connor Bohan from the University of Rochester worked with Judy Logan, who unfortunately is all the way in Copenhagen. So I get to introduce him and his work with Corey. So this is being recorded, so she'll be able to see it and get back to you. But I will let him do it.
Connor Bohan, as he said, I'm from the University of Rochester in Rochester, New York, and this summer I worked at Corey. Corey CORI is the Clinical Outcomes Research Initiative, and what they do is look at studies and the outcomes of GI procedures, and the chief way in which they do this is through the CORI software, which is software that allows people who actually do the procedures to enter in data about patients. That data is then de-identified, so the personal identifiers are removed from that data and it's sent to a database. And from there, that information can be used in studies. And CORI works with the study investigators to help them get the data, and then when they're ready to publish, they also work in the publishing so that those studies can get submitted to journals. And this is where I'm specifically working on. I'm helping with the publishing process. So the problem that I'm trying to solve is that there's currently no real system that they have for tracking projects that use their data and tracking the publications and even just the journal submissions that aren't publications yet. So on the right side, you can see what they currently do, and that's just a website that has a list of all the publications that use CORI data. And the problem with this is that you're required to add everything manually, and it's just a website, and there's no searching features. So it's kind of a bare minimum, and it doesn't have everything you'd really want. So the solution I came up for this was to create a web-based application, and this would allow people to submit projects into it and journal submissions, and so that CORI users could track projects and submissions. This is only available to CORI employees, just a matter of security. But it's based on a database, and that database contains projects and the associated journal submissions for those projects, and allows the search of that and the addition and editing of existing projects and journal submissions. So the first feature and the most important feature of my project was the search feature. This just allows users to search through the database, and you can search on projects and journal submissions simultaneously, and I'll show you how that works in just a bit. And there's a variety of parameters that were specified to me that you should be able to search on, and it should be noted that when searching on multiple parameters, it's more specific. So things are required to adhere to both of your specifications and not either or. So here is an example of the search page. The search you see is an empty search, which means it returns everything in the database. But you can see the fields on the top. Below that, you can see two boxes titled Test 1 and Test 2. This is dummy data, not actual projects. But those represent projects, and the italicized words below those are the investigators that are responsible for those projects. Within each project box, you can see smaller boxes, and those are indicative of journal submissions for that project. So you might have noticed they're color-coded. Black means that the journal submission is currently pending approval. Red means that the journal submission was rejected. Green means that the journal submission is accepted. And when on the very bottom one, you can see that it's in full citation format. That means that it's an actual publication, not just a submission to a journal. The second series of features is the adding and editing features. I decided to just go with the basic route and use a form field for this. Adding and editing projects is pretty similar. The only difference between adding and editing is that there is an ID field at the top of an editing page, and there isn't one at the top of an adding page. This is because each project and submission has a unique identifier in the database, and this is just used to identify this. So this is a example empty edit project page. So if you had a project in the database, it would have a unique identifier that would go in the CORI ID slot at the very top. I'll show you how the interface does this for you in a little bit. The rest of the fields are all the fields that correspond to boxes in the database. And at the very bottom, it has buttons for performing actions, such as saving the changes and deleting a project from the database. So I'm going to go into a bit of the design philosophies I used when creating this application, and then give you a little bit of a tour of the application, showing the process of adding things to the database. So a few of the things I decided I'd do is that search would be the basis for most actions. It's just easier that way. If you search first, it's the easiest way to locate something in the database. So I tried to make that the start for almost any action. Also, because this application is for a few expert users, I decided to do less hand-holding and make the interface broader so that more actions could be completed in fewer steps. Another thing I decided to do was use a technology called Ajax. Ajax is just a way of making things feel responsive and not requiring page refreshes. It keeps the application smoother. So I decided it's a little bit harder to use, but I decided that was worth it. I also tried to use a consistent look and feel. So that means a single CSS or a single style throughout the whole application. And finally, I tried to make sure that every action had some feedback for that action. So when a user submits something to the database, a little box pops up on the bottom of the page and indicates whether that action was successful or if it failed for some reason. So I'm just going to take you through adding a project and adding a journal submission to that project. At the very top of the page is the navigation bar. It allows you to get to any page within the application in one click. So the first thing you want to do is click the Add Project button. That'll take you to the Add Project dialog page. The first two fields are the title of the project and the principal investigator. Those are the only two required fields. All other fields are optional, but they include funding sources and various dates. It should also be noted that I tried to use the most specific type of form entry as possible. So for funding sources, there are a limited number of options, and you can have several of those options, so I decided to use a multi-select. You'd also notice that if you click a date box, it would pull up a calendar widget, which would automatically format things for you. So that was just another little design principle I used. So after everything's filled out, click the Save Project button. Now, when you go into the search, that appears in the database. Again, an empty search, so everything's returned. And then when you want to add a journal submission to that, there's a little plus icon. There's a series of other icons, all with tooltips to explain what they do. The plus icon means add journal submission to this project. That'll take you to the journal submission page. It automatically fills out the core ID for the project that it's associated with, which in this case is 34. And the rest of the fields just fill in and then hit Save Submission. And now that brings you back to the search page. And as you can see, the project that we've created now has an associated journal submission, which is outlined in a black box, indicating that it's in the pending stage. So it hasn't been accepted or rejected yet. So I'd like to thank my mentor, Dr. Judy Logan. The person I worked with in designing this is Luke. I didn't have time to add this in, but Chris looked over my my presentation and gave me some suggestions. I'd like to thank the rest of the Corey team and the DMICE internship program. Are there any questions?
Yes, I'll go. So I'd like to know more about who uses the Corey data and how does Corey get information about their projects and publications?
So that would really be a best question for Luke, since this is the area he kind of works in. He's the one who would be using this, and I'm not quite sure how he gets his information, but he does work with people who are publishing the studies, and so he'd be the one using this interface for the most part. Okay, thank you.